This part will be pediatric leukemia and the health of the population. Eva Steliarova-Foucher from France. Welcome.
Good afternoon, ladies and gentlemen. I'm pleased to present here some very fresh results and try to make some sense of what they mean. I work in the International Agency for Research on Cancer, the mission of which is to do cancer research for cancer prevention. And specifically, I'm involved in the section of cancer surveillance, and our aim is to provide reliable data on cancer burden around the world. And I'm specifically interested in cancer burden in childhood. So, to start, this picture just shows the weight of childhood leukemia among all the cancers that occur in the age of 0 to 14. You can see that this is the most common cancer in almost all populations around the world, apart from some populations in Africa and perhaps the black population in the USA. So these data are taken from a study which is called International Incidence of Childhood Cancer, Volume 3, that we are now preparing. And these data include cancer registries that contributed data for the whole 10 years of this period, 2001 to 2010, and have passed through the quality checks and were evaluated as high standard cancer registries. So this is just to show the extent of the study. We were working with almost 500 cancer registries, and more than half will probably be presented in the publication in the end. The current analysis, the slide that I showed before, are based on almost 300 cases. We have two separate analyses for ages 0 to 14 and 0 to 19, and this is because in the age 0 to 14 we have additional data sources in the form of pediatric cancer registries, which register cancers only within this age range. So overall, you can see that the cancer incidence in children is about 140 per million population, and when we look at 0 to 19, it's 156. When we look at the cancer incidence of leukemia, you may note that there are quite large differences around the world, and they might be five-fold differences for the total leukemia. You may note that in African populations, leukemias are much less common than, for example, in white populations of Europe or North America, and the highest rates can be seen in white Hispanics population in the USA. When we look specifically at lymphoid leukemias, the dark bars, the differences between the populations are even larger and may go up to six-fold. You can also maybe note that there are the lymphoid leukemia constitutes a smaller proportion of the total leukemias in Eastern Asia and in Southeastern Asia than in the other populations. So why do we have all these ethnic differences or differences across populations in the world? So first explanation might be diagnosis, because as you already heard earlier, not all cases might be diagnosed, either because the families do not seek help, especially in low-resource countries, or the diagnosis cannot be done because of technical difficulties. There is also possibility that not all the cancers that have been diagnosed are counted. And this is sometimes used as an argument against the reports of increasing incidence rates in populations. But for example, in this slide, where you can see the increasing rates of childhood leukemia in the US population, and where the ethnic groups are compared, whites compared to white Hispanics, we can see that in the same population, the incidence is increasing faster in Hispanic population than in the non-Hispanic. And it would be really no reason why there would be more ascertainment in this section of population. And as you can see, for the other type of leukemia, acute myeloid leukemia, there are not really differences in the trend of increase, which is another support for the ascertainment, not always explaining the increasing rates in childhood leukemia. So another explanation of ethnic differences could be genetic, and this is quite acceptable because of numerous chromosomal abnormalities seen in childhood cancers, including leukemia, familial aggregations that are linked to leukemia, such as Fanconi anemia, some congenital syndromes, for example, Down's syndrome, which also is related with increased risk of childhood leukemia. And then there are also more and more epigenetic processes that show that there are some links with the risk of leukemia, which is also not, which act selectively in different racial groups. So there is also environment that could cause differences between races. For example, such as proximity to heavy traffic roads, use of pesticides either in agriculture or in household for treatment insects. Another source of pollution is radioactive pollution or electromagnetic fields. So there are many studies looking in these environmental risks, and many of them show association with increased risk of leukemia, even though there are other studies that do not confirm this risk. So these are all questions. There are also socio-economic factors that can differ between countries and between racial groups, such as socio-economic status of the whole populations or within population of different families. The family size, for example, it was shown that the families that have more children have reduced, the children have reduced the risk of childhood leukemia. The maternal age at birth of a first child is also suspected to increase risk of childhood leukemia, while breastfeeding is seen to be protective. And then there is also influence of health care. In fact, in the countries which are high-resource countries and they have very good health care, they may also produce effects on increasing incidence rates by, for example, diagnostic, especially prenatal X-rays, also by therapeutic radiation for cancer or other serious diseases, use of chemotherapeutic agents to treat cancer, which causes new cancers to occur in the survivors. And in general, the health status, which is quite high and good in these populations, make the pool of cases, which is larger than in the populations where many children die young of infections. So in this slide, we can see the proportional distribution of neoplasm across the age groups. And you can see that leukemia is very common in young ages, but then its weight drops down towards adolescence. And when we look at the incidence rates in teenagers, 15 to 19 years, again, these are lower than what we saw previously for 0 to 14. And also the variations between the countries and populations are a little bit smaller, about threefold. So on this slide, we can see the age-specific incidence rates of leukemia. And you may note that in populations where overall rates of leukemia are high, they also have much higher incidence of leukemia in very young age. And this pattern is especially marked for lymphoid leukemia and less for acute myeloid leukemia. So there were some hypotheses created to explain why this high incidence of leukemia may occur in such a young age in children. And there is a postulated hypothesis, Greaves' hypothesis, about delayed exposure, according to which deficient infectious exposure in infancy may be a risk factor for developing the common form of acute lymphoblastic leukemia in children. And there were several studies that looked into this hypothesis and tried to confirm it or refute it. And many of them provide support to this hypothesis. For example, they found higher risk of leukemia in children that are born as first, which means that they have less stimulation of immune system by less infection, protective effect of early daycare of children. Then risk of leukemia was also found lower in the cohort which was infected by enterovirus. The antibiotics that were bought or taken during the young infancy also had some effect on reducing risk of leukemia. And there was also another large French study which showed a series of correlations, such as early common infections, children born later than first, then daycare before age of 1, breastfeeding and regular contact with pets. All these factors seem to have a protective effect and decreased risk of childhood leukemia. But there are also other studies, and this is one example, in which this hypothesis did not get support. So in summary, leukemia is the most common childhood malignancy. It has about six-fold variation across populations, and it's probably caused by multiple determinants that may also interact. There are different patterns for different leukemia subtypes, of which acute lymphoid leukemia constitutes between 60 to 80% depending on population. And there are multiple risks that either are proven, which is very rare, apart from perhaps radiation, and others that are being investigated, such as chemical exposures, infection, environmental pollution, and various lifestyle factors. So this is just to show, I hope, that the data from population-based cancer registries provide an invaluable resource to evaluate and assess cancer burden, to use this assessment for intervention in populations, and also to reveal patterns of occurrence which may give rise to hypotheses which need to be then tested and confirmed, and then used for prevention. So, but these data would be useful only if they are complete and of good quality, which depends on pathologists, clinicians, nurses that are maybe sitting in this room. So I did not prepare an acknowledgement slide, but I would like to thank very much to all the registries that contributed the data, including the Turkish Pediatric Cancer Registry, the support from UICC, Union for International Cancer Control, which supported this study financially, and also the organizers of this meeting. Without all this help, I would not be speaking here today. Thank you very much for your attention.